welcome. I would like to thank everyone for taking time out of their day to join us today. And I'm going to start us out on our topic of advancing the treatment for both leg and back pain as alternatives to pain medication. Dr. Andy Davison will be joining as well. So the question comes up, what is a pain management specialist? Well, a pain management specialist is someone that sees patients that has a goal of trying to find the source of the pain and to address it in a manner that maximizes quality of life. So for example, we want to see folks have less pain, less suffering, be able to sleep better. But really what everyone is here for is to, optimize their function, the ability to live and do things. So we study advancements in techniques and methods, trying to stay away from heavy opioid use to maximize those goals. And one of the main challenges we face as we age as humans is back and leg pain. So we're going to dive into that and share with you some exciting advancements that have come out that we've had a wonderful experience in our practice, being able to offer these treatments to patients. So have you ever felt like, maybe you've worked your whole life and retired, and as long as you're sitting in the chair reading or watching TV, you feel pretty good, but you want to get up and, do some gardening or walk, and you just say, you know what, I can only go so far, and I start to get trouble with my legs, I just have to sit down. So we may say, well, why do you have to sit down? And it could be a combination of numbness, balance problems perhaps, or just pain and weakness. And once they sit, oftentimes they'll say, well, once they sit a while, I kind of charge up and I can go again, but not for very long. And this is kind of a recurrent theme. So that's one of the most common things we see. And often this problem can be a result of problems in the spine, often known as spinal stenosis. So that's going to be the focus of our topic as far as the diagnosis. And spinal stenosis, Dr. Davison will get into a little more granular detail with that, can present with trouble walking, with weakness in the back, pain in the hip, pain in the legs, and can also cause numbness. So people may have tried various things for this, like heat, ice, over-the-counter things like Tylenol, ibuprofen, stretching exercise, going to the gym, chiropractic care, physical therapy, a lot of these different things, and maybe even some prescription medication. So oftentimes they'll lead to cortisone shots. Maybe the family doc will give a cortisone shot, or perhaps you've even had an epidural injection done in the spine that has worked, but the pain sort of comes back. And then, you kind of look for other options, and maybe you've been to the point where a surgeon has talked to you and you're kind of on the fence or a little bit afraid of taking that leap into a fairly major back surgery. So this can often be a result of spinal stenosis. And spinal stenosis is essentially a result of aging of the spine with, let's go ahead and advance the slide, please. It can be a result of degenerative disc disease and disc bulging and osteoarthritis, which can cause chronic back pain, trouble with the legs, weakness, numbness, and tingling. Next slide. So these people, they really resonate with this. We have pictures in our office with patients walking kind of with that lightning bolt you can see in the leg, and then they'll see this grocery cart and they'll really resonate with that. And they go, that's me. When I go to the store, I always volunteer to grab the cart because I never really thought about it, but I can do so much better, less pain, and I can go further. It's like charges my battery up. So what they're really doing is they're, by using that cart, you're flexing your spine forward, which kind of helps physically with the spinal stenosis that we'll talk about in a bit. Next slide. So I kind of alluded to some of these things that can be tried, the physical therapy, the spinal fusion, which is a kind of a one-way street. It can be helpful, but you can't really turn the clock back on that procedure if it's a failure. And then opioids, we've all known about the opioid epidemic over the last 15 years or so, and there's pretty much a huge overuse of opioids 10 years ago, and we're seeing a reversal of that trend because we want to minimize addiction and optimize patients' function, both mentally, psychologically, and physically. Epidural steroids often can be helpful. If a patient gets by with 1 or 2 a year and they're functioning well, it can be a nice avenue. But once those start losing their efficacy or duration of effect, may want to think down the road a little further. Some other interventional things we do as pain specialists are stimulators. That's kind of like a pacemaker for pain, we'll say. We're not going to get into all the details of that. And then a radio frequency ablation is for back pain that's related to arthritis that's not really going into the legs. And that's basically an ablation, or a lay person may say, the pain doctor burnt the nerves in my back. I don't like that term, but that's kind of word on the street. What we have to be careful about is letting patients know we can't do that on the sciatic nerve. That's just for small pain nerves in the kind of around the bone. So that's often a misnomer. Next slide. So this affects millions of people. There are more than 14 million people in the US that suffer from this wear and tear resulting in spinal stenosis. And actually, for our Medicare folks, we think of as 65 and over. It's the #1 reason for spinal surgery. And as you're going to hear, I think that one of the big take-home messages that I'd like for you to take from this talk, before this procedure we're going to talk about came along, we often had a patient that sort of, went down this line of treatment and got to the epidural. Maybe it worked and it stopped working. And there was a kind of a black hole between that and going for a laminectomy or a spinal fusion, which is a big step. So this procedure we're going to talk about kind of fills that niche void, which has just been amazing for our practice over the last 3 years to improve quality of life and function. Next slide. So this is spinal stenosis. I'm going to go ahead and turn the talk over at this stage to Dr. Davison to kind of go into some detail with our slides on this issue.
Thank you, Scott. I'm Andy Davison, one of the doctors here in our Newcastle and Muncie offices. And just like Dr. Taylor mentioned, spinal stenosis really is a natural age-related process that tends to happen over time to a lot of people. It's not necessarily the result of an injury. It's the matter of the longer we live, the more our discs wear out, and the more arthritis we get, it kind of creates a narrowing on the spine. So it's, when people say stenosis, it's a lot of the time it's synonymous with narrowing, and a narrowing around the nerve as it exits the spinal cord going down the leg, or narrowing around the spinal canal itself. So over time, people may notice that their walking or standing tolerance decreases gradually to a point where they say, you know what, I've worked my entire life, and now that I'm retired and I want to enjoy going on walks around the park or on a hike, but I don't have that tolerance anymore. So these are the people that we're really targeting with this message, is that you don't have to give up the things you enjoy just because of narrowing around the nerves. Saying that, it is important that people do find good relief with either flexing forward, like Dr. Taylor was mentioning, over a shopping cart, or they feel fine sitting down, but they would just like to lead a more active life. We can advance the slide, please. So I want to talk about the Vertiflex procedure for lumbar spinal stenosis. This has been a really game-changing procedure for a lot of patients that have tried all the conservative measures, such as medications and therapy, maybe even some of the steroid injections, but they're hesitant or maybe not great candidates for moving forward with a traditional big spine surgery. It's appealing to patients because when we talk about how minimally invasive it is, it's a nice alternative to a long back surgery that's inpatient in nature. So you'll see on this slide that on the right side, the Vertiflex implant is a small titanium spacer that fits in the bones that you can feel. When you feel your back, you can feel the little bony prominences. Those are called your spinous process. And this spacer fits in between those spinous process just to hold it open. It doesn't manually distract that space, but it holds it open enough so that when you stand and walk, you're not going to have a compression of the nerve in that bony channel as it comes off. Some of the common questions we get about the procedure is, it has been around and FDA approved for greater than 5 years. The procedure itself only requires about a 3/4 inch incision. It's an outpatient procedure, meaning you come in the morning and you're usually home well before lunchtime. Again, we're not removing any bone. We're not cutting out any tissue. We're just adding this implant. Therefore, it does not fuse that level, so it's not going to limit someone's mobility with twisting or bending. It just prevents that compression. Since it is such a small incision, it does prevent a lot of the risk of infection, and it's durable. A lot of times people say, I got good relief with an injection, but maybe it only lasted me 6 months. The beauty of this procedure is that it's meant to be sustainable, long-term relief. It may be the last thing someone needs. We can advance the slide, please. So the cartoon on your right side of your screen shows kind of the nature of how this device is inserted. It's inserted through a small cannula that's placed through that tiny incision, and just to remove that little bit of tissue in between those bones, and then it's slowly opened up in that space to kind of brace that space open. It is unique in that there are multiple sizes of these implants, so it's not a one size fits all. They're measured in millimeters, all the way from an 8 millimeter at the smallest to a 16 millimeter at its largest. So depending on each person's anatomy, you can get a custom fit size that helps brace that space open uniquely just as much as you need it. Once that spacer is in, it does prevent that compression of the nerves, and the intention is to allow the patient to feel as good as they do sitting down, even when they're standing upright or walking. We can advance to the next slide, please. So after the procedure, patients always ask, well, how much downtime is there? Am I restricted to my activity level? And that's a real positive aspect of this procedure, is that you come in the morning and you're walking out on your own strength just a few hours later. There's a small incision that we close with some sutures and oftentimes a staple or two in the skin. And you're able to do pretty much all of your daily household activities and walking and things like that you enjoy without requiring a lot of downtime. We do typically provide a lumbar spine brace to often act as a reminder that, hey, I had something done, and to limit bending, twisting motions, or lifting much more than, say, the weight of a gallon of milk. And that just helps the body heal and the implant to stay in place over the course of the first several weeks. And then at 6 weeks, we see you back in the office. We get an updated x-ray to make sure that everything looks stable from the time of the procedure. And at that point, you're free to resume normal activities, whether that's playing tennis or pickleball or golfing. That's the nice part, is that you'll be able to resume those activities. And that's really the goal, kind of like Dr. Taylor said, the goal is to restore function. It's not to, the primary goal is not to do something more than a steroid injection or something less than a surgery, but it's to provide just enough relief for you to get back to the things you enjoy. We can advance the slide, please. So the reason I think we, as a practice, are very excited about this procedure, not only is it minimally invasive and a great alternative to other treatments that have existed for many years, it's that when we see patients back in the office, it's very satisfying for us to hear their stories about how they're able to do more, maybe play with grandkids or walk with their friends. And it's not uncommon at all for us to see patients back at that 6-week or 12-week mark, and they say, I've got 85 to 95% pain relief, and that never gets old for us to be able to help people in that way. The results that have been studied across the nation correlate with that very well. At 5-year real world data from real patients say that 9 out of 10 people, so 90% of people, are very satisfied and with the procedure itself and with the pain relief and improved function that they're receiving. We can go ahead and advance the slide, please. To reiterate, not every patient that walks in the office is necessarily a great candidate for a procedure like Vertiflex. A lot of people are, but our practice is really focused on what can we do, what's the least amount we can do to achieve the greatest improvement in your function. So if it's therapy and some medications, wonderful. If it's an injection or something like the Vertiflex, we're happy to do that as well. Another minimally invasive option we have for people that say, oh, well, I've already had a big spine fusion and I don't have those spinous process bones anymore because they removed them in a big surgery, is a spinal cord stimulator, which is very similar to, like Dr. Taylor mentioned, a pacemaker for pain. And that's often a good alternative when maybe Vertiflex is not an option in some patients. We can advance the slide, please. I think Dr. Taylor mentioned the radiofrequency ablation. That's a procedure, again, where it's focused on treating arthritis pain that stays just across the low back, doesn't really go down into the legs as much. That can be a great option for patients that have arthritis pain. And it is another good option for the correct patient. I'm going to go ahead and turn the presentation back over to Dr. Taylor, and at the end we can field any questions that people may have. Thank you.
Thank you, Andy. So to sort of wrap up, it's really fun to talk about a procedure that you have passion for, and Dr. Davis and I both do, because we work in the real world in a busy clinic, and it's been incredible for us because our patients, we've done a lot of these procedures, and our patients are our best, I guess you could say, marketing or whatever, because a lot of folks that end up coming in are friends of a patient that had this experience. So, and I've been in practice 28 years, and I must say I've never seen quite like it. So I want to go back to Vertiflex a little bit and kind of field a few questions that may come up. Who's a candidate, who's not. So your doctor will help you sort through that. But, before you come to us, it would be helpful to have plain images, of course, of the spine. And then if possible, an MRI scan, or, some patients can't have an MRI, so they may have to have a CT scan or what's called a myelogram. So we're looking for folks that have had at least 6 weeks of conservative care symptoms. So that could be exercise, doing physical therapy, a chiropractic visit or treatment, maybe some injections and things like that, just not the first onset of back pain and sciatica, obviously. And then the criteria is someone with what's considered moderate spinal canal stenosis. And we'll be able to help you sort through, is it mild, is it moderate or severe, based on the imaging studies. And there are some other things we need to look at as well. And that's where the plain x-rays come into account, because some people will have some slippage of the vertebrae. It's called spondylolisthesis. So we want to make sure we have good outcomes when we do the procedure. So we want to minimize patients that fail to improve from the procedure. So sometimes we'll even do an x-ray where we have you bend and lean back to check for some of these salient details. But as far as the experience, it is an outpatient, like Dr. Davison said, and we do this with what's called a MAC anesthetic. So a MAC anesthetic is where you're asleep, but you're not intubated with the air pipe. So you don't have that risk of the real sore throat from being intubated and the potential risk of a general anesthetic itself. And coverage is quite good. Medicare and Medicaid covers this procedure. And the recovery time, as Dr. Davison mentioned, we'll put you in a LS corset or a back brace. I like patients to wear it almost all the time the first week and about half the time the second week. It sort of serves as a reminder to be careful as your back's healing the first few weeks, not to what I call torsion, when somebody bends and twists at the same time, kind of like with a shoveling move or a golf swing move. Those are things we want to avoid for a few weeks, and try to squat when we're bending down to reach things, and not to lift over about 10 pounds for about 6 weeks. And a lot of patients will ask, well, can I travel? Can I go to the airport? Well, there will be a medical card that you'll have. So, usually going through security, you can mention to the security people you're going to probably set the alarm off. You have a medical implant, and present your card, and they'll just typically wand the patient down. But in the long run, we've seen patients get back with function. Oftentimes, the pain that really got them there was their function, where their hips and legs hurt, where they couldn't stand or walk for a long time. They may still have some arthritic back stiffness and pain in the back, but they really, they'll say, well, I can deal with that. Now I can function and walk. My legs don't give out. I don't have to sit every few minutes. But the procedure is not designed to restrict your motion long term. After the healing period, we carry that out for about 6 weeks. We're pretty conservative. I think Dr. Davison mentioned we'll x-ray at that time and see if the implant's in position. And if there hasn't been any movement of the implant, I will remove restrictions at that time, but encourage them to use good common sense and ergonomics when lifting, try to lift appropriately. And then kind of the last item is, when will I feel better? And I would rather, say, let's expect up to 6 weeks to notice it. It depends how long somebody's had stenosis. The longer those nerves have been compressed, the longer it can take for that to sort of wake up, if you will. But we've kind of seen in our practice around week 3 is when the patients will really start to notice a change. That's not uncommon for week 3 to be the week they're starting to say, wow, things are really starting to change in a positive way here. So that concludes our discussion today. I really appreciate you taking the time to join us. And we are excited about this and want to share the information with you all, and look forward to continuing to offer this procedure to appropriate patients. It's been a very rewarding experience. So again, thank you for taking the time to join us today. Appreciate it.
Yes, thank you.
Goodbye.